This is a case report of a type of skin cancer known as basal cell carcinoma. The patient was an elderly lady who presented with a skin lesion over the left temporal region and which is gradually growing over the past year. She had frequent episodes of bleeding. A biopsy done outside suggested a basal cell carcinoma. Clinical examination revealed a 2 by 2 centimeter skin lesion over the left temporal region, which was well defined. Under the scaly scab was an ulcerative lesion that bled on touch. She had no regional lymph nodes palpable. The surgery that was performed was an excision, which was done under local anesthesia, and it was reconstructed with a local rotation flap. The final histopathology report confirmed the diagnosis of a basal cell carcinoma with clear margins. These are the intraop and postoperative images. As you can see, this is the tumor itself. This is the tumor once it was excised and reconstructed 1 week later and 6 months later. Basal cell carcinomas are non-melanocytic epithelial skin cancers that arise from cells found in the basal layer of the epidermis. Exposure to ultraviolet rays of the sun are one of the leading etiological factors for these tumors, and therefore they tend to occur on exposed areas of the body like the head and neck, the arms, etc. In most cases, a biopsy is advisable. However, in select cases, that is for very small lesions, a one-stage excision is both diagnostic as well as curative. Basal cell carcinomas are low-grade, slow-growing skin cancers that almost never metastasize. Reported incidence of metastasis is less than 0.1%, and for this reason many prefer to call them basal cell epitheliomas instead of basal cell carcinomas. And because they rarely metastasize, a metastatic workup, which we would normally do in most other cancers, is rarely required in these situations. The mainstay of treatment is surgery. Aim of surgery is complete excision with optimal cosmetic result. Due to their low-grade nature, a tumor-free margin of only a few millimeters is usually sufficient for a cure. Surgical options include knife excision plus or minus reconstruction, electrodesiccation and curettage, Mohs micrographically controlled surgery, and cryosurgery. Topical modalities include 5-fluorouracil 5% topical cream. The indications are patients that cannot undergo either surgery or radiotherapy. This is useful only for very superficial lesions. It needs to be applied twice daily for 2 weeks for at least 6 weeks. And in carefully selected patients, that is those with very superficial lesions, there have been reports of up to 80% cure rates. Other topical modalities include interferon, imiquimod, and tazarotene gel. Basal cell carcinomas are radiosensitive, and radiotherapy can be used for lesions that are not suitable to undergo surgery. Cure rates with radiotherapy are about 97% for primary tumors. The downside with radiotherapy is it is expensive and time consuming. Side effects include radiodermatitis, collateral damage to adjoining structures, and of course long-term sequelae of radiotherapy are well known. Other treatment modalities include photodynamic therapy, systemic retinoids, and hedgehog pathways inhibitors like vismodegib. Thank you.